Hi everyone, I'm Dr. Mika Riley. I am a board certified physical therapist in Seattle, Washington, and an ACL rehab specialist. So I am also going through an ACL injury myself and had surgery about 4.5 weeks ago. So I've been documenting my journey and expressing frustrations that I have as I go through my recovery, but also highlight some of the cool parts of my journey as well. So as I mentioned, I'm 4.5 weeks post-op. I had an ACL revision using my patellar tendon and had a medial and lateral meniscus repair and an LET procedure. Now, I also had to have my old hardware removed, which I had a little bit of a complication with because this was an unknown type of screw that was used that has been inside me for many, many years, but unfortunately was unable to be removed to its entirety during the surgery. So some of it broke off and then some of it stayed in. And so it's been, half of it is in there. So, now where I'm at this point in time, 4.5 weeks, I think back and reflect on what I want for my clients and where ideally they should be at this point in time. Now, everybody's recovery is so different. Their surgeon is different, how they heal is different. All of these factors that we need to consider, like their age, their responsibilities in life, all of those things need to be considered when somebody's going through the ACL journey and rehab. So I'm trying to give myself grace during this time because I am much older than I was, and I'm healing a little bit differently this time, and there was a lot more trauma this go around. So looking at my progress, my extension has been doing wonderfully since the very beginning. I've been able to hit between 0 to 3 degrees of hyperextension pretty nicely. I had a little bit of difficulty getting my quad to fire up, and mainly I would say that's a lot to do with the lack of, I had a lot of swelling, so just a lot of inhibition at the time, so I had to take care of that, and then on top of being unable to get into a position that I can optimize my quad contraction. So I've been using a lot of tools like BFR, blood flow restriction, and NMAS device. So it's an electrical stimulation to help improve the contractibility of my quad. And I'm proud to say that I have definitely improved since 2 weeks ago and have really good ability to contract my quad, but I'm still working on it. It is not 100% great, but it is a lot better than what it was 2 weeks ago. As far as my flexion goes, I am concerned about my flexion. I had my 2-week post-op, and at that 2-week post-op, I expressed concern about not quite hitting 90 degrees. I maybe hit it a couple times, but was consistently hitting between 50 and 70 degrees of flexion. Now, we need to take some of this with a grain of salt, right? Like, I had a lot of trauma and wanted to give my knee the benefit of the doubt, and there was just a lot of trauma, a lot of swelling that was there, and more than what I was used to. And I was trying to accept, well, maybe this is going to be a much slower process in terms of my flexion or my range of motion in general, just because of the amount of trauma my knee endured. Now here I am, fast forward to 4.5 weeks, almost 5 weeks post-op, and I am hitting a dead stop, a wall, essentially, with my flexion, and I'm able to get into 90 degrees, and then I am abruptly stopped by a hard wall. I have no pain, and it doesn't hurt, it doesn't feel tight, it just won't budge. So I was a little bit concerned about this during week 2, because week 1 I had been doing pretty good in terms of my flexion. I felt like I was hitting pretty close to 70 degrees, it was coming up, and then it kind of quickly declined. And it may have been because I clearly did too much at work and was a little bit overzealous in what I was doing and standing a little bit more upright, and so more swelling came in. But the biggest thing that I'm thinking about, and what I was thinking about back 2.5 weeks ago, was arthrofibrosis. Now, if some of you don't know what that is, arthrofibrosis is scar tissue formation, and it is a complication of ACL reconstructions. And in terms of the research, what we're seeing is that it depends on a few factors. And in terms of who is at risk for this, it can happen to anybody. But we're often seeing this in people who have early intervention surgical procedures, and their preoperative range of motion values. If they don't have full range of motion going into the surgery, they just do have a higher risk of potentially developing this as a complication in their recovery. And then the last thing is, surgical technique. There's some of those things too, and it's just really hard to really pinpoint the surgical technique and what that is. It could be tunnel placement, it could be maybe just a lot of things, right? The other thing is females are at risk for a lot of things. The research hasn't really said enough of why females are at risk, so I'm just going to put that one to the side, because I feel like females just get a big hit with these injuries, and I just don't think there's enough information out there to just say yes, females in general, but without a why. But what we do for sure know is early intervention and preoperative range of motion values. Now, I did have surgery pretty quickly, and one of the reasons why was because I had a flipped meniscus tear. So I had a bucket handle tear that did flip, that was in my notch and restricting my ability to fully extend my legs. So I was pretty stuck in a bent knee position, and I didn't feel like I was really going to make that change or improve if I waited 2.5 weeks to have surgery. So that was a risk that I decided to take, and here I am today, almost 5 weeks post-op. My 6-week post-op is coming up, my visit with my surgeon, and I'm going to bring up these concerns with my surgeon. What I'm doing in the meantime, I decided to, instead of rush to my surgeon to talk about this immediately, I'm going to take the next 1.5 weeks to really increase my aggressiveness on my range of motion and see if maybe I can make a change with it. That way I can say I did everything I possibly could before we talk about other options. Now, if I do have arthrofibrosis, I would undergo, and it's all surgeon dependent, and it all has to be based on the evaluation that you have with your surgeon. But usually the typical protocol is to do a lysis of the adhesions. So basically go in with a camera arthroscopically and then, clean it up. The other option is a manipulation under anesthesia. Now, every surgeon's different. They might do both, they might do one. But my hope is that it would just be a cleanup of my scar tissue, but I don't know the extent of what maybe the inside of my knee looks like. So we'll just have to see. But, I was reflecting on my rehab, and, I want what's best for all of my clients going through this. And I am the one that guides them and gives them a plan. And if we have significant setbacks, I figure that out for them. So this has been a very eye-opening, very great learning opportunity for me to really keep tabs even more on things in terms of progress, and trying things and then turning around and switching it up when we need to. And I felt like with my own rehab process, I'm doing that. I've had to be very creative in ways of trying to find how I can improve my range of motion. And, I feel like I've tried a lot of things, and I've, wall slides, heel slides, trying to get into it functionally, trying to, of course, thinking about swelling, making sure I'm getting on top of that and getting it out of that position, trying to work with my kneecap a little bit to help things move a little better. And I'm hitting a wall. And, I was talking to my colleague about this, that it's frustrating. It is so frustrating to have a setback. And, I'm frustrated because as a ACL rehab specialist, this is not the journey I envisioned myself to be on in terms of my own ACL rehab, but it is what it is, and I accepted the fact that I might have a setback, and I didn't know when it was going to happen, but it's happening a lot sooner than I expected. And that's okay. It totally is. It's just really frustrating. I work with a lot of ACLers every single day, and I see them day 3, day 4, maybe even day 5 out, and able to hit their range of motion values really, really quickly, or just right off the bat, honestly. And I'm super stoked for them and super happy for them, because that's a sense of independence that comes back to them. And that's hard for me to see going through my own ACL rehab, but I'm a lot older than they are, and I had a lot more trauma, and this is not my first time. So I'm just trying to remember all of that, and then just remember all the wins that I have. So anyways, that's my update, and that's where I'm at, and I'm hoping that I can get this knee situated in terms of my flexion within the next week and a half, but I'm going to be very cautiously optimistic. And if I need to have an arthroscopic lysis of the adhesions, then we will do that. And I couldn't be any more excited if this is what's going on, because this intervention is a really good intervention to help and aid in your range of motion if there's a significant wall in terms of scar tissue obstructing your range of motion. Granted, I will tell you, as long as you are doing everything possible to address your range of motion limitations on your own, that's the next best option, to make sure that your adhesions aren't blocking you. So anyways, that's my journey. That's where I'm at. And comment or ask me questions if you have any.